My name is Antonio Barros, member of the Aorta Diseases Unit of the Hospital de Sant Pau in Barcelona, and I present two cases under the title Intramural Hematoma with Surprise. The first case is a 74-year-old male, smoker, hypertensive and dyslipemic, well-treated, who presents a very intense centrothoracic pain that starts abruptly and at rest, radiates to the back, and is accompanied by vegetatism. At the time of presentation, the patient has a very high blood pressure, 230 to 120, with no other notable semiology. This is his electrocardiogram showing an unknown fibrillation with a controlled heart rate. A bedside echocardiogram was performed showing no abnormalities other than mild to moderate aortic regurgitation. And the study was completed with a CT. I show you first the one on the right, which is the one that we do with contrast. You can see that the aorta presents in the distal portion of the arch a thickening that extends along the entire descending thoracic aorta and up to the middle of the abdominal aorta. That displaces the calcium in some points. Here you are seeing it with a crescent form. In the acquisition that we performed previously without contrast, you can see how the thickened part presents an high attenuating area, which allows us to diagnose type B aortic intramural hematoma. In this case, the patient was not complicated. He was admitted to the critical care unit and treated with labetalol and morphine. The patient remained asymptomatic and well controlled, and a radiological study is made, a CT scan at 72 hours. I show you the slices comparing the CT of day 0 with the CT of day 3, the proximal portion of the descending aorta, the middle portion of the descending aorta, and the diaphragmatic portion, and I show you the caliber of the aorta, including the thickening, that you can see that there was a progression in some points due to the flaring. So, well, at this time we were considering treatment. However, reviewing the study we did on day 3, it is a synchronized study, and this thickening that was also visible in the initial study, which you can see is a completely circular thickening, and in which you can even see that the adventitia loses the sharpness that it usually has. This led us to wonder whether it was an acute aortic syndrome, a type A hematoma, or whether if it could have been associated with an inflammatory process. Reviewing the initial CT scan, here you can see how there was 2 ways in the study without contrast. In the descending portion, you see an hyperattenuating thickening. However, in the ascending portion, we do not see this finding. Checking the supraaortic vessels also shows this thickening that had also gone unnoticed in the left carotid artery. So the patient underwent a blood test that included inflammatory parameters, and in this case what was striking was that he had a very high CRP and a very high ESR, despite the fact that the patient was not anemic, and we completed the study with a PET CT scan, and here you are looking at the PET CT scan, in which the metabolic activity in the entire thoracic aorta is surprising. Notice how both the ascending portion and the descending portion up to the area where the aorta was practically thickened show a very increased metabolic activity. This patient was treated, stabilized, and an attempt was made to separate the aorta wall from the lumen with an endoprosthesis. And he was treated with 3 boluses of methylprednisolamide, 250 milligrams a day, 3 consecutive days, and later it was prescribed prednisone at 60 milligrams a day. And here I show you the radiological evolution of the ascending portion of the aorta in a study at the 21st day. Notice how there is a reduction in the size of the aorta with a reduction of the wall thickening. Case 2 is a 63-year-old woman, in this case a very poorly controlled and lipemic hypertensive. 4 years earlier she was diagnosed and treated for a breast neoplasia. She presented frequent headaches in the last year that had been related to poorly controlled hypertension despite treatment with valsartan and amlodipino that generated leg subedemas and diuretic was associated. The patient presented a very intense central thoracic pain with sudden onset, also at rest and radiating to the back. At the time of admission, she presented very high hypertension without any other notable abnormalities. The electrocardiogram and the echo did not show pathological findings, and the study was completed with a CT showing a thickening of the descending aorta wall. Here you can see an hyper-attenuating thickening of the aorta wall in the non-contrast phase. You can see how the calcium is defined in the internal wall. Wall aorta thickness is visualized from the subclavian to the iliac bifurcation, and it was also noteworthy that the inferior mesenteric was occluded, although it was redrawn by collaterals distally. This CT allowed the diagnosis of type B intramural hematoma. The patient was admitted to the critical care unit with the diagnosis of uncomplicated intramural hematoma type B and treated with labetalol and morphine. The day after the admission, the patient continued with pain and uncontrolled hypertension and presented fever. Blood and urine cultures were negative, and the analysis showed a very high CRP and ESR. On the third day, the patient persisted with fever, pain, and hypertension. It was decided to request a control CT. The radiological control was performed on the third day, and here you can see the radiological evolution. You can see on the left, at the level of the proximal descending aorta, what had been placed at the beginning and how the hematoma remained stable in this control CT. Due to the clinical presentation of the patient and the CT findings, we decided to complete the study with a PET-CT, and here you have the result of the PET-CT. You can see how there is hypermetabolism in the wall of the aorta combined with parietal areas that are ametabolic, that may correspond to the hematoma, and you can also see how this metabolic activity is diffuse along the entire descending aorta. It is not a very intense uptake, and it is heterogeneous. With all this, the diagnosis of inflammatory process was established, and he was also treated with methylprednisolone in 3 bolus of about 250 milligrams 3 consecutive days, and later also with prednisolone 60 milligrams a day. And here you have the radiological evolution. We did a control study on the 15th day and at 1 month of treatment, and here you can see how the aorta has a significant diameter reduction as a consequence of a significant decrease in the aorta wall thickness. The patient was afebrile, pain-free, and with normal blood pressure under oral prednisolone treatment. The diagnostic criteria for giant cell arteritis are these according to the American Society of Rheumatology. In the first case, the diagnosis is established by age, by the alterations that he presented in the temporal artery, and by the very high ESR. And in the second case, apart from not having alterations in the temporal artery, she did have cephalgia of recent onset. At this point, what we can ask ourselves is whether these two patients present an aortitis and not an intramural hematoma, or whether the intramural hematoma is possibly the complication of an aortitis. What we know is that aortitis is a form of expression of both giant cell arteritis and Takayasu, as well as others, such as arteritis for IgG4. In the follow-up series of aortitis, some patients present with acute syndrome, and so these patients who have had aortitis have to be followed closely because the aortas can dilate and can become complicated. But patients who are diagnosed with giant cell arteritis, even without the need for aortitis clinics, should also have an imaging study that includes the aorta. Why? Well, because this aortitis can be inapparent and can have complications in follow-up. We should think about it when we visit a patient who has an intramural hematoma and this has atypical clinical features, and to reach the diagnosis, multimodality is required. In our 2 cases, we have used CT and PECA-CT, and MRI could have been useful. The most important point is that treatment should be combined. To avoid aortic complications, to control inflammation in the acute flare, and to avoid future flare. And the discussion remains open. Thank you.